Welcome to Make America Healthy Again. Join Dr. Charles Antinori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antinori.
This is the Make America Healthy Again podcast. This is Dr. Antinori. And today my guest is David Kelter, who's a resident I trained a few years ago. He's working down in Louisiana these days. Dave, you want to just give a little bit of your background?
Sure, yeah. So went to college at Northeastern in Boston, went to the Caribbean for medical school at St. George's in Grenada, did my residency with you, Dr. Antinori, up at Inspira Medical Center in South Tennessee. Came down to Louisiana for fellowship in MIS robotics and foregut training, which is a lot of hiatal hernias and bariatrics, and I'm sure we'll get into that later. And I really enjoyed my time in the South, so wound up staying down here, signed on to a contract, and I'm still working for the same hospital system that I was trained in for fellowship.
Yeah, great. And you said you're doing kind of robotic surgery a lot?
Yeah, I would say my practice is about a 50-50 split between elective robotic surgery and acute care surgery, which would be any emergency that comes out of the ER. So, you know, my typical week, I'll have 2 days for the week where I have block time in the OR, where I'm doing strictly elective cases. So things like hernia repairs, gallbladders, hiatal hernias, which is when the stomach sort of herniates through the diaphragm and up into the chest. And then the other half of my practice would be patients that come in through the ER. So if you've got a perforated bowel or a perforated stomach or appendicitis or what we call cholecystitis, which is just an infection of the gallbladder. Any of those cases, you know, I would take care of straight out of the ER. It's not really a planned thing. It's more emergent.
How many of those are you doing robotically? What would you say? The appendix, gallbladders,
I would
viscous? Yeah.
Sure. Yeah, I would say as far as appendixes go, I really reserve the robot for the more complicated cases where I think up front we might need to do something more extensive. Either they've been sitting on it for a while and there's a huge abscess cavity, and I'm worried that part of their colon might also be inflamed and I might need to take some of that. But I would say still probably 75% of my appendixes are laparoscopically performed. The one advantage sometimes that you get with the robot is you can do 8mm ports as opposed to the 12mm port for the stapler when you do it laparoscopically. And that can save you a fascial closure and a potential incisional hernia. But again, you know, at a hospital, I'm working in a community hospital for the most part in Louisiana. So access to the robot to save 4mm on an incision isn't always, you know, appropriate or available. So right. I still do most of my appendixes laparoscopically.
Right.
As far as gallbladders go, I would say near 100% are robotically done. It's really, I would say so.
Yeah.
Visualization is excellent. Lots of tools for it. The hook is really, really nice on the robot. It's a lot bigger and can be used for blunt dissection. And I would say ICG and being able to flip on and off on the robot to sort of visualize the ductal structures is something that, while it's not entirely necessary, definitely helps with your confidence as a surgeon when you're dissecting out those critical structures.
That's the light that shows you theoretically where the common duct is? Is it a light or is it a
It's an immunofluorescent stain that you give through the IV. The liver metabolizes it and then pushes it into the lymphatics around the ductal system. So I would say it works in about, in my experience, it's worked in about 50, maybe 60% of cases. But then there's often times where either it's not timed correctly. You have to give it 45 minutes before the surgery usually. So it's not as apparent. There's other times where the entire liver is lit up, and so is the gallbladder.
Yeah.
And so on ductal structures.
That's kind of with all those type of things that seems to be what's happened. All those things where you inject something, you know, with a certain time, and it's the timing always seems to be a problem. But again, it's another help, you know. And we're one of the other. I've been doing these podcasts. I've done two with a friend of mine who's really into AI. And he's saying that, and Chris also too, you know, with Chris Bashan, I think you listened to some of them, and they're saying that, you know, the AI fellow was saying how like AI can put AI on the robot and it can tell you, hey, you're getting near the common duct, you know, stuff like that.
Yeah, I mean,
amazing.
I think that AI augmentation for the robot is something that we're going to start seeing roll out over the next 5 years or so. I remember when I was interviewing for fellowship, there are a couple places that were already experimenting with it a little bit, where the AI will intraoperatively will tell you what step you're on and sort of guide your dissection. Say specifically, I saw for an inguinal hernia. Yeah. They were pointing out ureter, it was pointing out the preperitoneal flap, like all those types of things.
Wow.
And I know that they're already using AI augmentation for colonoscopies and getting biopsies on polyps and things like that. I think that the new robot, the Da Vinci 5 that just came out, the computing power of one of those robots is equivalent to the entirety of the national fleet of the prior series of robot. Mm-hmm. I think the reason that they put that computing power in there is because they foresee, augmentation and a lot of AI integration. I don't think it'll make our job, but I think it'll just make our job easier and, kind of point out some things and hopefully make you.
That's something again for lay people that might end up watching this. When we talk about robotic surgery, it's not like a robot doing a surgery. It's a surgeon sitting at a console running a machine, which we call the robot. And they really, the little experience I've had with it, I can see the real advantages compared to like laparoscopy, which again was a huge breakthrough. My God, that really changed surgery in my lifetime. But you could just do so much more. It's so much easier too to do complicated things with the robot.
Yeah, I would say the way that I usually describe it when I'm talking to residents is, they're both laparoscopy.
Right.
Traditional laparoscopy, right, and the robot. They're just two different tools to accomplish the same goal. And if you happen to feel more comfortable on one, then that's great. But I do think that there's a lot of value, especially in residency, learning laparoscopy, because when you're handling tissue on the robot, you don't have, on the new one, you do get some tactile feedback, but most places you won't have that tactile feedback, and sort of knowing what it's like pulling, inflamed tissue versus normal tissue with your hands and understanding what it looks like, you at least have a couple more frames of reference. You don't absolutely need laparoscopy to be a robotic surgeon, but it definitely helps, especially up front.
Yeah, I think definitely. And I'm glad to hear you say, that you're still doing a lot of the appendixes laparoscopically, because I think the big issue, and again, in Make America Healthy Again, we're trying to make it healthier, but we're also trying to do it cost effectively. And like that, there's no question the robot, it costs significantly more. Now, the more it gets used, I guess the less it costs per case, basically, but it does cost more. And, for appendixes, I don't know, for a routine, like you say, if you see a woman with a really bad CAT scan and it's an abscess or something like that, that's different. But, for the routine, kid, it goes full circle. When I was a resident, I remember we used to, a young kid came in with right lower quadrant pain, tender, wasn't hungry. We'd get a CBC, and it really didn't even matter. He didn't even have to have a white count, frankly. You would take him to the OR, no CAT scans, no nothing. And we were right. At that time they used to say, you should be right 80% of the time. They didn't want you to be right 100% of the time, because they felt if you were right 100% of the time, you were waiting too long. Nowadays, you're probably right closer to 100% of the time. They upped the bar to 90 during around 2000 or so, when CAT scans got common. It increased its accuracy.
Right. That's actually to your point. I tell residents that all the time now, that traditionally appendicitis is a clinical diagnosis, and there's an accepted non-appendicitis rate of 20% or something like that.
Right.
With the advent of CAT scans, now the sensitivity is 98%, the specificity is 95%, something to that degree. And I actually think gallbladders have become far more a clinical diagnosis. You get that patient that comes in who's 60, diabetic. They just have non-specific symptoms. Then you go in and the entire gallbladder's necrotic. It looks
that used to amaze me too. That the gallbladder being a bigger organ, you would have thought that CAT scans and ultrasounds would be more accurate. You know what I mean?
Right.
But that happens all the time. Somebody that doesn't look really too bad at all, and you get in there and it's a horrible gallbladder. Which is another good argument, I guess, for the robot for the gallbladder. That when it gets complicated, you've got more options. And you touched on another point too. I remember when the robot first got started, really one of the first couple of years that I was at Inspira, so it would have been 2012, 2013. I went down to Alabama, where Birmingham, Cerfolio, Dr. Cerfolio was there. He was the real originator of the robot for lung surgery. And he by the time I went there, he had published like 1,200 lobectomies or something he had done robotically. But watching him, I ended up having my kidney stone the day I went down there, but that's like another story. So I did get to watch him for a while, and he was very nervous. I mean, he had a bedside assistant, and he kept asking the bedside assistant, "Are we pressing hard? How hard are we pushing on that?" And that was a big knock on the robot for a while, the lack of proprioception. But like I say, I've been hearing from Chris Bashan and other people about the robot that they're building in more proprioception into it, and you have a little bit better sense of what you're doing. But like you say, I think it's good to be able to do laparoscopically. I really don't think you're going to end up doing every damn case on the robot.
No. I mean, and to your point, like those patients that come in with pneumoperitoneum, it's on a case-by-case basis. Like I've done plenty of gram patches or modified gram patches, which is an operation we perform to fix a hole in the stomach, whether it's caused by bacteria or, taking too much Advil. There's plenty of reasons that you can develop a hole in the stomach. But, that patient's got to be hemodynamically stable. Their blood pressure can't be too low. Heart rate can't be too high. You don't want to put the sickest of the sick on the robot. You're just asking for trouble when you do that. So, I think there's still a huge role for open surgery that every resident needs to be comfortable with, at a baseline, at a minimum.
Remember that lady we took to the OR that one night, that was sick and the anesthesia was like, "You're not doing her laparoscopically."
No. Yeah, exactly.
Anesthesia didn't want any part of us doing her laparoscopically. Yeah. But, why don't we talk a little bit about, bariatric surgery? Because, I know you've doing a lot of that robotically, and what do you think is the advantage? What's the best operation? What do you think is going on with that?
Yeah, I think it's as far as the best operation goes, I think it's a case-by-case basis, for the patient. My training, I haven't been doing very much bariatrics as an attending, just because of sort of the workflow setup where I'm at, and I'm trying to get that set up. But in fellowship, I did a ton of bariatrics. And I would say the three main operations that we performed were a gastric sleeve, which is simply just removing a part of the stomach. It looks like a Nike check or a banana by the time you're done. And it restricts how much food you can eat, and also takes away the part of the stomach that signals hunger, that produces ghrelin. Second is a bypass, where we essentially create a small stomach pouch and rearrange the intestines so there's less area for nutrients to be absorbed when you eat it. And then a SATI, which is essentially a combination of an old operation that we used to do and a gastric sleeve. So we cut out a large piece of the stomach, and then the first part of the bowel that is just past the stomach, we reconnect to bypass a lot of the other small intestines. So it's got both a restrictive component in cutting out a lot of the stomach, and then a malabsorptive component in the sense that we've bypassed a lot of bowel. So your food just hits, halfway through the small bowel as opposed to at the beginning of it.
No.
And I would say, like, our practice down here, a lot of the time was offer the sleeve first to the patient. Unless, there's huge comorbidities, like severe diabetes, or the patient's extremely morbidly obese and really wants to pursue a gastric bypass first, we usually would start with a sleeve, just to restrict how much they're eating and reduce their appetite, by cutting out that part of the stomach that produces it. But I think there's other things to consider. If you've got a hiatal hernia and you're overweight, then you just go straight for the bypass. So I think there's a lot of things to sort of consider here. It's very much patient by patient when you're deciding what kind of operation to do. But I will say, I think that bariatrics in general has become less in demand over the last few years, just because of the new GLP-1 drugs that have been coming. I had Michael Kachmar, was the fellow at LSU, and he did purely bariatrics for the year that I was down here. So I actually got to work with him quite a bit.
Mike, that's where he ended up there? Yeah.
He did his bariatrics fellowship at LSU, and we shared the same hospital for about 6 months, which was really fun. He actually wound up in Tampa, Florida, following fellowship. I think he's working for USF or Tampa, something like that.
Okay.
But having said all that, he was telling me, he was looking for a bariatric job coming out, and he wound up getting one that was both clinical and research and did very well for himself. But he said, looking at sort of the job market, it's shrinking compared to what it used to be, just because the demand isn't quite there. And I think there's two different schools of thinking. One school of thinking is that the weight loss drugs will start to really push forward the patients that need surgery because either A, they're not responding to the drug, or B, they get to a certain plateau with weight loss and then need an operation. So that's one school of thought, which would lead to more patients in a couple of years from now.
Right.
And the other school of thought is that, which I tend to believe, is that the drugs will essentially produce a nice effect on weight loss, and that a lot of people will opt to not go under the knife because they're already happy with the results that they're getting. So it really depends, though. Those drugs aren't proven for patients with BMIs greater than 40, 45. They're really in a nice subset of patients with a BMI under 40. They see that weight loss that they're looking for. But I happen to think with second, third generation GLP-1s coming out, the pill form coming out, that's all just less incentive to move towards the operating room. And I have a feeling that 20 years from now, bariatric surgery will likely be limited to patients that either one, don't respond to the drug, or two, need a revision from a prior surgery. So there'll always be a need for it, but how great that need is may change over the years.
Yeah. It's interesting. You reminded me of a lot of different things. The same type of thing happened in heart surgery, and it's funny when stents came out, and actually stents, when they first came out, coronary bypass was the big cardiac operation, as you know. And that was, we're doing hundreds of thousands a year, and then when the stents came out, it had the potential to eliminate that. But initially, it actually increased cardiac surgery because the cardiologist would then cath people that they wouldn't have cathed. If the person was not considered a surgical candidate, like somebody really old or had a lot of other comorbidities, they might not have cath, but they would cath when the stents came out. They would cath them with the idea that maybe they would stent them, and then when they realized it was triple vessel disease or a left main or something like that, they didn't want to stent them, so it ended up actually increasing cardiac surgery for a while. But then and then also, of course, the stents, the bare metal stents and things had so much restenosis down the line. It wasn't until the drug-eluting stents came out that eliminated the restenosis problem. And then that's when it really just killed cardiac surgery. It decimated it. And now, to make matters even better for the patient and worse for the surgeons, is they can even most of your aortic valves are getting put in, which amazes me that you can do that through an artery, but they're doing it. And I've been following the studies, and basically they started with people who were inoperable. Then they went to high-risk surgical patients. Then they went to medium-risk surgical patients. About the only ones left, and it's a small group, is like low-risk, like a young guy that needs an aortic valve or something like that. You could argue, that maybe you should do them the old-fashioned way, and he might not need a second operation, but.
And how many of those patients are you really going to get? Those patients.
That's it. That's not going to be a whole lot of people now.
Right. Yeah. But so I suspect that bariatric surgery will probably follow sort of a similar, projection in the next few years. But that's not to say, I think that the one of the main values in bariatric surgery, especially during fellowship, especially during fellowship, in a robotics fellowship, is you have to use just about every single skill that you've got. Whether it's retraction or you're dealing with like a ton of fat in the abdomen, you're sewing anastomoses, you're using the stapler, you're working in every quadrant. So I really do think that a lot of the benefit, at least training wise, is you get very, very comfortable doing just about every maneuver on the robot. I'm great that I got it. It's nice too when a patient comes in, status post Roux-en-Y, which down here in Louisiana, the average BMI is like 40 or something like that for the average person walking around.
I'm going to say the South is the heaviest. I think Mississippi's the worst state.
But Louisiana's number 2, right behind it.
I figure it would be right there. Yeah, the diet and everything.
Blood ads, and so a lot of patients have had previous bariatric operations, and they'll come in with an internal hernia, where go to the OR emergently, and rather than having to XLAP them, if you feel people, with that anatomy on the robot, you can feasibly just put them on the robot and take care of it as long as they aren't too sick, which is nice.
Yeah. Yeah. So last thing I think we should talk about, moving on from, we don't think we have to talk too much about the meds. You've kind of covered it. I don't know where they're going to end up, but like you say, I think better ones are going to come out, and it will be in a pill. We've seen this recent studies already showing it that they actually work in a pill, which will really expand it a lot. But the point of both with the surgery or the meds is changing lifestyle and get people to improve their diet and exercise, and that's what really would make this country healthier again, and cheap. Diet and exercise are just so much cheaper than medicines and surgery.
Yeah, absolutely. I mean, in the end, like even a gastric sleeve being a restrictive operation, the end goal is similar to a GLP-1, which is just, it's a tool to get you to change your habits, right? Gastric sleeve is an actual restrictive procedure, and it's going to force you to change your habits because you can't eat as much.
Right. The stomach pouch is made smaller, just again for lay people listening. So you get full faster, basically. Yeah.
Correct. And same sort of idea with the GLP-1s is it induces gastroparesis or doesn't allow your stomach to move and empty. And so it's a similar effect in that it's, it's a restrictive sort of medication. And so, I talk to patients all the time and just let them know, these are tools to get you to a healthier lifestyle. You can't just have this procedure done or just take this medication. It's supposed to get you into the better habit of regulating what you eat, watching what you're eating, like staying, very much on top of your macros, figuring out, how many calories in versus how many calories out, and just getting you to a healthier lifestyle that is either one, sustainable when you come off your GLP-1, or two, is sustainable when your stomach starts to reaccommodate and you can eat a little bit more.
Right.
So, yeah, I mean, it's all just pushing you towards being a healthier person in general.
Right. And another point you make about the gastric sleeve, again, as a guy that has seen a lot of gastrectomies. I started my residency before Tagamet. Tagamet came in I was about a third year resident, and within 2 years, the number of gastrectomies that the chief residents did went from 100 to 40, and it's probably down to about 10 now. Something like it's pretty much only cancer right now. But I saw lots of people that had gastrectomies for ulcer disease, earlier in their life. 15, 20, you operate on them for something else, or maybe for an ulcer, ulcer again, or whatever you're operating on them. That stomach practically looks normal again. I mean, it can stretch back up to basically normal size in 10, 15, 20 years,
Oh yeah, and you see that when you're converting a sleeve to a bypass, plenty of times. That sleeve has definitely stretched and expanded. But to your point, I'm pretty sure that if I remember correctly, bypasses actually initially began as an alternative to those surgeries for ulcers, like distal antrectomy and all that. Was born from that.
Yeah. One of the reasons I was never a big fan of bariatric surgery was the operation that was popular when I was in resident, my first year intern. 2 months into my internship, I get called to assist on they're doing a cut down on a 400-pound, 18-year-old Hispanic girl. This was before we even had good central lines. And so we were doing a cut down looking for a cephalic vein on this girl so we could put her on hyperal because she had a JI bypass, which was the operation of de novo of the time basically, and she'd gone into hepatic failure, so she needed to be hyperalimented at 400 pounds. Yeah, to hyperaliment the girl. And I thought, this is nuts. But then the operation, disappeared fast enough, and now I think the operations they have now really work, and and make sense. But again, if you can avoid them, it's nice. But I think last thing was to talk about diet. What do you think about diet? I've read a lot about going plant-based. And do you think how do you feel about that?
I don't have much evidence-based material to back it up, but I do know that getting protein from meat sources does seem like there's a lot of utility to it. You get different amino acids like leucine and things like that help, support muscle growth and all that type of thing. I don't think there's anything wrong with going into a plant-based type of diet as long as you're still getting the amount of protein and fats that you need. But I personally, try to just keep it a balanced diet. That's usually what I recommend to my patients as long as they can, maintain it. Just keeping track of, the carbs and the fat do sneak up on you if you don't watch it closely. But yeah, I don't think there's anything wrong. There's a lot of my friends don't like using whey protein or don't like in general, just don't tolerate meat very well.
Yeah.
And in that case, I don't see anything wrong with going to a vegan-based protein or anything.
Yeah, I read the guy Michael Gregor has written like 3 books on how not to die, how not to diet, and how not to age. And he especially how not to die. His first book was very much, and it's very scientific. I mean, he quotes the best available articles. And again, nutrition is not rocket science. You know what I mean? Like it's hard to, and he'd be the first guy to say that it's hard to get good publications and think, because it's so hard to assure compliance and all that sort of thing. But he really feels strongly in that book that, the vegan diet is probably the best. But I would say, and even he in the book, he's not like he's saying everybody should stop eating meat. You know what I mean? He stopped short of saying that. And that's kind of where I feel. I've cut down tremendously on the amount of meat I eat, but I still eat it. And I agree with you. I think it is for protein. It's a faster source and it's good to have a different type of source, for the protein. And then there's the big thing about was it B12 that you're supposed to take if you're a total vegan. I've heard all sorts of explanations of why that's true and why it's not true, and but that always bothered me a little bit.
Yeah, I mean, I think as long as you're taking a multivitamin, which especially for bariatric patients, I recommend they all take multivitamins.
I do too. I take a couple times a week. I take a multivitamin just to be on the safe side.
B12 and folate have super long storage times in your liver. So I think as long as you're taking a multivitamin, you don't really have to worry about those deficiencies.
Right.
But having said that, at least in my mind, I'm like, we're omnivores. Our GI tract's been sort of adapted over, so long to process meats and protein and whatnot. So, and I just like eating.
Well, you know what he would say, what Gregor says to that, is that we only tame fire. I forget whether it's 50,000 years ago or 250,000 years ago, something like that, that man has been able to control fire to cook. So, according to him, we probably didn't eat a whole lot of meat until then, of the 6 million years of human evolution or whatever. It's only been like the last 250, which is a significant amount of time, and we're obviously omnivores. I mean, even the way our teeth are and everything, I'm not going to say you should never eat meat, put it that way. But I think cutting down on meat would be a good idea for a lot of people, I
mean, especially like those red meats with the heavy nitrates and everything getting your stomach. I always feel a little bit worse after eating that red meat. But, my brother and I make this point all the time. You look at a silverback gorilla's diet and they're just eating plants in the middle of the jungle, right? They don't take in much natural protein, as far as meat-based protein goes.
And they're pretty strong.
I would say so.
Last finish, Dave. I know we wanted to talk about exercising. That to me, because to me that is, I really have been exercising almost my whole life, and especially since I started in Skira, I've really been very faithful, like 5-6 days a week. Pretty much an hour each time on. I do a lot of different routines. Some of them are shorter than others, just to keep variation so you don't get bored like doing the same thing over and over again. But like right now, I'm doing Body Beast, Sajid Kalev. You ever see who he is?
Yeah, I see it. Yeah, you look just like him too.
What?
I said you look just like him too.
Mr. No, I'm nowhere near the beast. But to me, I've always done that. I started with a guy named Joe Weider. You know who he was? You ever hear of Joe Weider?
No.
Joe Weider, nobody knows who he was. He died maybe 10, 15 years ago. He's the guy that brought Arnold Schwarzenegger to the United States. And he ran the Mr. Universe pageant, programs. And they used to criticize him that Arnold won so many times because they felt it was like rigged because he was sort of like Joe Weider's boy, and Arnold won, Did you ever hear the story about Arnold's heart valve operation? Did you know he got, he needed an aortic valve. You never heard this?
No.
It was on Jay Leno. I knew it had happened. He ended up needing an aortic valve, and he was relatively young. I would say he was in his late 40s or 50s. This is like 20, 30 years ago, and it was the Ross procedure, where you take, they had homographs, and one aortic valve, most aortic valve replacements like that I did, we either used a porcine valve or a biological or a mechanical valve. St. Jude was the common one that we used for a mechanical valve, and that's still, I think, probably the case. But all of these ones that are being put in through the aorta are the biological valves, because they can fold the biological valves up and fit them in through the catheter and get it into position. Mm-hmm. But that was the two common valves. And then the homograph came along, which is a freeze-dried human, aortic valve. And so there was a lot of people felt it was better, but it was kind of a lot more complicated to put in. And then the Ross procedure went one step further. It went in and took the person's own pulmonary valve, put the person's own pulmonary valve in the aortic position, and then put a homograph in the pulmonary position, which amazed me anyway, because when I did my congenital heart surgery, we did a lot of pulmonary valvotomies. The pulmonary valve doesn't look like much at all, compared to the aortic valve. It doesn't look nearly as strong to me, as sturdy or as thick as the aortic valve. But apparently this worked. It was really considered the really cool aortic valve operation to do, especially for a guy like Arnold, who was young and healthy and didn't want to take anticoagulation and all that. So anyway, he had it, but something went wrong. He had to go back. They had to go take him back to the OR, and he ended up with two homographs. And this is, like I say, this has got to be. It was Jay Leno was still the night guy, because I saw him interview on Jay Leno. So how long has it been since he was the Tonight Show? It's got to be at least 20 years, I would say. And Arnold still looks good, But he had to go back, and he has to. So he's talking to Jay Leno, and Arnold's got the famous line. He goes like, Jay, my favorite line was, "I'll be back." He goes, "You never want to hear that from your heart surgeon."
That's interesting. I didn't know that Arnold Schwarzenegger does. And he's still fit. He still goes to the gym.
He's still fit. He's not nearly as big as he was, though. He's really slimmed down. He's not really as defined as he was, back then. He was unbelievable. But like in the first Terminator, oh my God, it was really unbelievable. I have to tell another story. We got to get it. I went out with the identical twin of Linda Hamilton. She worked the coop for Leslie. She was even in the second Terminator movie. Yeah.
Wow. That's awesome. How is that?
Anyway, but like I said, I think in terms of making America healthy again, losing the weight is a big part of it, and diet and exercise are the easiest and cheapest, and I enjoyed it. I have to say, before I exercise, this kind of like weighs on me a little bit. I got to work out today, but then when I do it, I really feel better about myself and about everything, and I sleep better.
Absolutely. Listen, I say to a lot of people all the time, like it's calories in, calories out, right?
Right.
And so
books knock that, but that is physics. That is the truth. There's no question. The diet books say, well, you can't just say that, but yes, you can.
You can, because it's just math. It's how it works.
Yeah, right.
Calories in, calories out. Yes, there's nuance in there, but in the end, it comes down to that. And the other thing too is, you work out every day, you get a metabolic boost. You become more insulin sensitive.
Right.
You're able to digest food better. You'll be able to partition the nutrition that comes in more appropriately. And if you're working out once a day, that's a metabolic boost once daily. You're not just burning the calories that you burn during the workout. You're also sort of increasing your basal drive to burn calories.
Right.
And so, I've shifted to like doing workouts in the morning because, I think that it just helps me wake up a little bit. And it just gives you a win under your belt before you go out and start the day. But in the, like we were saying, in the end, it comes down to calories in, calories out. Yes, there's nuance in there with sort of the partitioning of those calories, but I think any successful weight loss program or any successful really just gaining your health back program should include some form of exercise, even something as simple as an incline walk or take a walk for getting an extra 2,000-3,000 steps a day. That goes such a long way into fat burning,
Right. Yeah, I always say, it's been shown in the cardiac literature, 20 minutes of walking 3 times a week cuts your chance of a heart attack. That seems like nothing. You know what I mean? Like an hour of walking a week cuts it in half, something like that. And it's amazing.
It makes such a big difference. And, I think that's one thing that a lot of these patients going for bariatric surgery need to keep in mind is, when you're committing yourself to a surgery like that, you're not just committing to that surgery. You're committing to an actual attempt to change your lifestyle and become healthier. And it takes more than just the operation. The operation is just a tool to sort of jumpstart the process, right?
Right.
You got to be able to put in the work. And to be honest, it's not the worst thing. I think most of my patients feel much better just overall, having got out in the sun and walked around for 20 minutes or going to the gym, you feel better by the time you're done.
Absolutely. Well, listen, we have a long time. It's really good to hear from you. We're trying to keep in touch more.
Yeah, absolutely.
If I get down to Louisiana, my publisher is in Metairie, which is right outside of. And I keep saying, if the book finally gets picked up by a mainstream publisher, I'm going to come down there and have dinner with him. And I'll definitely stop by and see you. You're not that far away.
No, I'm like a 35-minute drive from Metairie. I know exactly where that is.
Oh, good. Yeah.
Yeah.
All right, Dave. We'll see you. Thank you very much.
Yeah, of course.